So we're continuing talking about renal issues, and now we're talking about pyelonephritis. So at this point, we're talking about the kidneys themselves, right? So this is inflammation of the renal parenchyma and the collecting system. There's a whole bunch of different organisms that can cause pyelonephritis, and specifically now we're talking about acute pyelonephritis. So we're talking about things like bacteria, and this includes E. coli, Proteus, Klebsiella, or Enterobacter from the intestinal tract. Then some other issues include the fungi, protozoa, or viruses. The biggest problem, once again, that we're worried about is urosepsis. And this is when you're getting the systemic infection arising from a urologic source. And the problem is we need to have prompt treatment for this as quickly as possible. Otherwise, it can lead to septic shock and death. So this is somebody that has acute pyelonephritis. So you see how everything looks pretty hideous, actually. So in terms of the pyelonephritis itself, it begins with colonization and infection of the lower urinary tract from the urethra. So basically things are traveling up, right? So bacteria normally found in the intestinal tract, like things like E. coli, Proteus, Klebsiella, or Enterobacter may cause pyelonephritis. So they're going upwards. And some of the reasons why this may happen is there may be what is known as a vesico-ureteral reflux. So this is retrograde or backward flow of urine from the lower to the upper urinary tract. All right. So think of the word pyelonephritis, so nephritis, and kidneys themselves. Okay. So urine moves from the lower to upper urinary tract, or there may be a dysfunction of the lower urinary tract, so some type of obstruction. So things like BPH, stricture, or stones. Whatever the cause is, it doesn't matter. The end result is you're getting this bacteria basically moving backwards, okay? And it is now infecting the kidneys. Some of the other issues can be the catheter-associated UTIs. Can lead to pyelonephritis. And then when somebody's pregnant also, when you have a baby, there's a whole bunch of pressure, right? So with that, urine can also be going backwards as well. All right. So that basically the urine is going backwards and then it's spreading. Okay. Your clinical manifestations of classic ones are the fever, the chills, nausea, vomiting, malaise, and flank pain. And then the other ones that you may get are things like dysuria, urgency, and frequency. The patient can also have the costovertebral angle tenderness to percussion, and there's a nice picture in your book that you can look at to get a sense of where this angle is. In some patients, it may end up with things like renal scarring and decreased kidney function. So anytime you're seeing things like renal scarring and decreased kidney function, this is bad because now we're worried about things like AKI and a chronic kidney disease. So this can become like a really, really dangerous situation. The patient can actually end up dying from this, right? So this is why we're worried about things like pyelonephritis. So a whole bunch of different tests that they can do. Once again, know that they're out there, and some are invasive, some are not as invasive, right? So things like ultrasounds, CT scans, those are like the non-invasive types of tests that they can do. Your patient can have what are considered mild symptoms and also what are considered severe symptoms. So for the mild ones, usually the patient just has a short inpatient stay, or they're treated on an outpatient basis. So just keep it very simple. So what are you going to do for these patients? So fluids, NSAIDs, they're going to give antibiotics anywhere from 7 to 14 days. And then in some cases, they may need them longer, from 14 to 21 days. Ideally, the symptoms, if they're mild, will resolve within 48 to 72 hours. For the severe symptoms, they'll do some of the same things they did for the mild ones, so IV, and then convert to PO antibiotics, right? But adequate fluid intake and enough hydration. Make sure they're treating the nausea, vomiting, all of those different things. So same things, the NSAIDs, and then combination types of antibiotics as needed. If your patient has a relapse, then they can give antibiotics for maybe 6 weeks or longer as needed. If somebody keeps getting recurrent infections, then they can start giving like prophylactic antibiotics as needed as well. For the urosepsis, that was the most severe case that we don't want. So we want to make sure that we are giving the patient all the antibiotics that they need. We're promptly treating this as quickly as possible. And ideally, we're trying to prevent septic shock, basically. And we're trying to prevent irreversible damage. All right. You are going to look at table 45.5 once again. Just basically trying to see what it is that we need to do in terms of our nursing assessment. And this is going to be very similar with everything else that we've been talking about the renal system. Same thing. Some of your nursing diagnosis, so impaired urinary system dysfunction, acute pain, lack of knowledge. Pretty similar to everything else we've been talking about. So treatment is going to be very similar to what we talked about under UTIs primarily, and we'll have a class discussion about this because everything is the same at this point. Okay. So taking medication as prescribed, making sure we're monitoring for any signs and symptoms for any relapses or recurrences, and making sure the patient has adequate fluid intake, and making sure the patient is resting. For the chronic pyelonephritis, really the big thing is that now you have scarring, and so at this point we are worried about the patient going into end-stage kidney disease, right? So this is, we've discussed ESRD in another PowerPoint, so you're already familiar with what can happen in ESRD, but that's like chronic, so basically they're getting repetitive inflammations, and now they're getting scarring, right? So they are going to do either imaging or biopsies to see how bad the kidneys are infected and how much they are scarred. So the biggest thing is we're worried about end-stage renal disease at this point. So if they do end up having end-stage renal disease, we know how to treat that already based on our other PowerPoints. So that's really it. All right, so now we're talking about glomerunephritis, which is inflammation of the glomeruli. With this condition, you're also seeing tubular and interstitial changes, vascular scarring and hardening. So that's glomerulosclerosis, which can affect both kidneys. So it's the third leading cause of end-stage renal disease in the United States. And glomerulonephritis is associated with other kidney infections, nephrotoxic drugs, immune disorders, systemic diseases, etc. It can be acute, where you're getting sudden symptoms, temporary or reversible, and it can be chronic, so there's a slow, progressive, irreversible renal failure. And the biggest issue with all of these renal issues is that we can end up with end-stage kidney disease. So that is always the thing that we are monitoring for. They have another one known as acute post-streptococcal glomerulonephritis. So this is a common type of acute glomerulonephritis. It's common in children, young adults, and adults more than 60 years old. This develops in 1 to 2 weeks after an infection of tonsils. And this is primarily because of the strains of AB hemolytic streptococci, and you're getting these antibodies to streptococcal antigen. At the very least, I just need you to know that the acute post-streptococcal glomerulonephritis is because of an infection, a streptococci infection. The patient gets these streptococcal antigens, and they're not sure exactly what's happening here with this one. All right, so keeping it very simple once again. What are you going to see? So you're going to see generalized edema, hypertension, oliguria, hematuria, varying degrees of proteinuria, and fluid retention. You're going to see things like periorbital edema that progresses to total body, including ascites and peripheral edema. The urine may be smoky because of bleeding in the upper urinary tract. proteinuria, primarily because of damage that's happening to the glomeruli there, hypertension, abdominal or flank pain. In some cases, they're saying that the patient may be asymptomatic. So for all of these conditions, have a sense of what the clinical manifestations are, because I know like for all of them, the patient may be asymptomatic, so that's pretty much true across the board, but focus on the weird things that happen in each of these different disorders. That's how we will be dealing with this, okay? Your diagnoses, so just know that they have all these different ways of finding out whether or not the patient has the streptococcal glomerulonephritis. So they're looking at titers, they can do a biopsy, looking at the BUN and serum creatinines, all of that. So 95% of patients will recover, and usually conservative treatment is all that's needed, which is good. Some of them may progress to chronic glomerulonephritis, which is not good. But in terms of management, so it's rest, decreasing inflammation, hypertension, whatever that looks like, whether they're giving, antibiotics, maybe steroids even, medications for hypertension, diuretics, restricting sodium and fluids, all of that, restricting protein if that's needed, all of that, antibiotics if the streptococcal infection is present. So all of that can be done. So once again, it's the kidneys, so the treatment is going to be very, very similar. So once again, in terms of prevention, it's early diagnosis and treatment of sore throats and skin lesions, and making sure that basically the patient has the antibiotics and that they're taking the entire prescription for the positive streptococcal infections. For the chronic glomerulonephritis, so at this point, you're getting things like renal fibrosis, and this can progress to end-stage renal disease. So it's weird that in some patients they may have no history of kidney disease, and then they end up getting this chronic glomerulonephritis. So it's just odd. Some patients they may have what is known as an Alport syndrome. So this is an inherited disease that basically affects the glomeruli. There's a mutation that happens, and then you're getting an alteration in the synthesis of the glomerular basement membrane, and then that's why they're getting the chronic glomerulonephritis. So it does develop slowly. Patients are unaware, and then maybe they'll find it during a routine checkup, basically. So they may see things like abnormal UAs, increased blood pressure, or increased serum creatinine. And essentially the main issue is that they may end up with the end-stage renal disease. So that is the biggest problem with that. That's what we're worried about. So what are you going to see in chronic glomerulonephritis? So you're going to see some of the same things that you saw under the acute. So things like hematuria, proteinuria, increased BUN and creatinine, but now it's probably worse. And the diagnosis is going to be very similar. So they're looking at your history and physical, doing things like ultrasound, CT scans, biopsies, looking for any immune disorders, looking to see if the patient has been exposed to any weird drugs like NSAIDs. And once they figure out what the cause is, then they're basically just going to target that in terms of the treatment. They have this other one that I just left on here just so that you're aware of it. So this is the glomerular disease with glomerular crescent formations. And in this one, you can get loss of renal function in days to weeks. Key word here is rapid. So it's rapidly progressive glomerulonephritis. Just know that this is out there. Apparently, it occurs as a complication of inflammatory infectious disease. You're going to get things like hypertension, edema, proteinuria, hematuria, red blood cell casts. But once again, the treatment is going to be correcting fluid overload, hypertension, uremia, and any injury that can happen to the kidneys. So this may include things like corticosteroids, cyclophosphamide medications, plasmapheresis, dialysis, and transplants. For your purposes, you're going to focus just on the acute and chronic glomerulonephritis, and you realize that the treatment's actually pretty similar.